So good morning, members of the board. Thank you for having us here today. My name is Gillette Baltonado. Let me introduce Jenny Otteson, Stephanie Brown, and Erin Caney. We're very excited to present to you our proposal for the future of South Street Health Network. We have come up with a comprehensive care plan. We call it No Stroke. By the end of this presentation, you'll find that our plan is integrated and multifocal in that not only is it aimed to enhance patient care for stroke victims, but also to ensure that this care is affordable for both patients and your network. One major goal of this plan is also to promote the health for current members of South Street Health Network, as well as all the future members that you'll be able to attain by implementing it. So why don't we begin by meeting our patient, who's been the major catalyst behind this entire undertaking. Her name is Lynette Tate. She's 53 years old, and prior to her stroke episode, we know Lynette is a widowed mother of 3. She's never had medical or dental insurance, as she's always felt her health was good enough, and so she's never had this desire to seek primary care. Even when the Affordable Care Act 2 years ago forced her to get health insurance, she still never took advantage of all those free preventive screenings and medical checkups that were now made available to her. So in a sense, Lynette never saw this coming. Even though she had a grandmother who succumbed to the same illness, she still had these personal misconceptions of what care meant to her. She never used any of those resources that I just mentioned, which all would have easily revealed to her that she did have underlying medical conditions, such as diabetes, hypertension, and high blood cholesterol, all leading to her getting her stroke. Well, we know stroke is a large problem in this country. It affects nearly 800,000 Americans every year as the 5th leading cause of death. The biggest takeaway from all of this is that 80% of all of those stroke cases are actually preventable. So maybe Lynette did not have to have that stroke. There are 11 states in the southeastern US where the prevalence of stroke and all their risk factors are actually higher than the rest of the country. You can see this on this map with the regions shaded in darker purple. We here in Kentucky are right in the middle of all of that. Going through these statistics for the different risk factors of stroke that we listed for you, we can see that Kentucky has higher numbers than the rest of the country's average. Unfortunately, this places our state at number 47 out of 50 in national health ranking. Having said all of this, though, we are very confident that the recommendations we're about to make for you guys are going to be the stepping stone to tackling this larger issue at hand. So I will be going over the different barriers of care that pertain specifically to Lynette's case. Jenny will then discuss our clinical recommendations under this No Stroke plan. Stephanie will go over how we plan to integrate this into the community. And Erin will finally discuss the costs and financials associated with this plan. We've come up with a root cause analysis. We've identified many modifiable factors that all came into play to the poor quality of care that Lynette received at Hazard Appalachian. Our plan will target the majority of these factors, and we've highlighted them for you today. Specifically, we'd like to target the miscommunication and the uncoordinated care that she received. We're also looking at targeting some of the systemic issues, such as staffing and the electronic health record system. Also, we plan to increase the low health literacy within Perry County and the surrounding counties. Now, with a main focus on the triple aim of your network, Jenny will begin by discussing how our recommendations are going to enhance the patient experience.
Thank you, Gillette. So this part of our proposed plan emphasizes patient safety and how to optimally care for stroke patients as they come through your door. We've developed this into phases, but just to clarify, it's going to be continuous throughout the process, and there is actually a page in the appendix with a more detailed timeline, but we just want you to know that this implementation is going to occur in stages. So in phase 1, we really want to focusing on patient safety. We want to first target the EMS as they are the first point of contact with these stroke patients. We know that only 10% of the responders in Kentucky have received the rapid response stroke training that's offered by the American Heart and Stroke Association. So we really want to get them all on board and universally trained. We would like to look at forming a stroke team as they can assist staff with utilizing stroke protocols and stroke order sets, which are proven to enhance the delivery of care, reducing time to CT and lab completion, and streamlining the process, thereby reducing potential for errors and orders. Into phase 2, we're going to look at getting with the guidelines for stroke. the CMS and Joint Commission have set forth several guidelines for stroke, and while we would like to achieve 100% in all of them, we're going to first target one and have a pilot. So for example, at Hazard Appalachian, we know that education was low, so we would assess that after 30 days, and then in the phase 3, we will look at adding the additional measures as well as expanding this system-wide so that all the facilities within South Tree Health Network can get with the guidelines for stroke. We will also look at stroke units, and although these are very costly, you can do things such as arrange your ICU to have designated beds for stroke patients, as there's evidence that this improves the delivery of care, reduces the length of stay, and improves the functionality on discharge. Ultimately, we would like to look at getting recognized as a primary certified stroke center by the Joint Commission in Kentucky. This here is our recommended no stroke team, what we have in mind, and I'll let you know there is no particular order and it's not all inclusive by any means, but just to give you an idea of how diverse and interprofessional we would like this team to be. Everyone will be educated on one another's roles in their respective professions as well as within the stroke team, all with Lynette being at the center of care. We would like to appoint a champion physician that can help assist with keeping the staff engaged with this No Stroke initiative, having staff education and competencies, mock stroke codes so that everyone can be comfortable with stroke alerts and the use of thrombolytics. While we recognize there are challenges to this, if you utilize the staff that you already have and get their feedback and ideas, we're confident that this plan will enhance communication and coordination among your healthcare. Our plan also incorporates telestroke, which is now supported by the stroke guidelines. Essentially, this is the utilization of high video conferencing technology to access expert stroke care from a remote location. So in this model here, the Comprehensive Stroke Center is really the University of Kentucky, which is one of 2 comprehensive stroke centers in the state. And the rural hospital, or the spoke hospitals here, would be Hazard Appalachian. So as Hazard Appalachian is not staffed with neurologists, they could utilize the partnership that's already in place with the University of Kentucky, or the University Hospital of Kentucky. And we know Lynette did receive TPA, currently the only FDA-approved clot busting medication for ischemic stroke, but it's possible that she might have been transferred 2 hours away to receive a higher level of stroke care. Looking further into the patient's course of their hospital stay and admission, we think it's important to assess and address the transitions of care. So looking at secondary stroke prevention. Did the patients receive the appropriate medications? So we know Lynette was prescribed a statin for her high cholesterol, and this is perfect. We want to encourage to continue doing this, as this is also a measure per CMS. Also, maybe a discharge pharmacist on the team could review medications for appropriateness and ensure also affordability for the prescriptions, as we know that Lynette had financial concerns with her prescriptions. We don't want to only target patient education, but also family and caregiver education. It was apparent in Lynette's case that her family was not aware of the importance of the care that was required of her to have a quality of life after her stroke. It's important to also assess every stroke patient for rehabilitation. And we would also like to have a first follow-up appointment set in place before these patients even leave the hospital and go back to their home, as this is important because the patients, if they don't have follow-up care, they're prone to have readmissions for stroke-related problems. So this is not only important for the patients and bad for the patient, but it's also very costly to the healthcare system and the community as a whole. So there's a similar health system in North Carolina that published a study in Stroke Journal that showed patients having follow-up care, compliant with their follow-up care, they had a reduction in more than 12% in their 30-day admissions. We're certain and confident that with No Stroke initiative in place, we could achieve a goal of 10% reduction in admissions. More importantly, how do we have no stroke from happening in the first place, and how do we prevent it from happening? So I'm going to pass it on to Stephanie now, who's going to share with you our ideas of enhancing population health within Perry County and South Tree Health Network.
Thank you, Jenny. So Jenny just told you about knowing stroke, getting with the guidelines, and improving patient care. Now, I'm going to tell you about our suggested plan for stopping stroke from happening in the first place. As a framework for our community action plan, we selected the health belief model. The health belief model was developed in the 1950s by the United States Public Health Service as a means for predicting health behaviors. The model is based upon the idea that a person's perceptions shape their likelihood to receive health care. These include their perceptions about the severity and susceptibility to disease, as well as their ideas about the benefits and barriers to receiving health care. Also included are cues to action. Cues to action are environmental triggers that cause a person to act on their beliefs. This can be something as simple as a newspaper article or television ad, or something that hits closer to home, like the illness of a family member. Unfortunately, none of these things alone are enough to cause a person to act on their beliefs. This is evident in Lynette's case, where although she cared for her grandmother, who also suffered from a stroke, Lynette did not feel that stroke was a particularly severe condition or that she herself was susceptible to it. In order to address these perceptions, we have developed a multi-pronged approach to community outreach. The first part of our plan will be to focus on enhancing the health literacy of the community through the distribution of informational brochures and the implementation of K-12 programs using our partnership with the Area Health Education Center. Both of these programs will focus on age-appropriate education about stroke and stroke risk factors, and the informational brochures will also contain information about the minimal essential coverage offered by the Affordable Care Act. Although many Kentuckians now have insurance thanks to the Medicaid expansion and the insurance mandate, they don't realize that their preventive health services are available to them completely free of charge. As an addition to services already offered by the Area Health Education Center, we would like to improve the accessibility to free health screenings and free health clinics to Perry County's most underserved populations. To do this, we would like to increase the use of these programs and target places like bingo halls, grocery stores, and other places where people congregate. For cues to action, the first part of our plan will be to enhance or integrate the use of social media campaigns at all of South Tree Health Network's hospitals. With most hospitals in Kentucky already having over 5,000 likes on their Facebook page, we know that this will be a great way to engage the community and inform them about new initiatives at the South Tree Health Network. And finally, we would like to work on encouraging the use of worksite wellness programs, starting with Perry County and the South Tree Health Network. To do this, we will partner with the University of Kentucky and the Area Health Education Center using students and volunteers to go to employers and deliver information from the Centers for Disease Control 6-Step Guide. The 6-Step Guide is a comprehensive informational brochure with information for employers about worksite wellness programs that have proven to be effective and strategies for implementing those programs. Some of the benefits of these programs include a $3 to $6 return on investment for every dollar spent on these programs, as well as proven outcomes for employees, such as increased use of preventive care services and reduced absenteeism. The best part about our no-stroke approach to community outreach is that it's measurable. By using health assessments like the one found in your appendix, we can continually monitor the health attitudes of the community and adjust the focus of our plan to meet their needs. As you can see, this multi-pronged approach to community outreach successfully meets the triple aim of improving population health. Now, Erin is going to talk to you about the financial aspects of our plan and how they relate to enhancing affordability of care.
Thank you, Stephanie. As you can see, we presented you with two distinct plans for South Tree Health Network. But how can South Tree Health Network effectively integrate the no-stroke plan while also keeping in mind your goals for the future and your relationship with Bluegrass Blue Cross? Our proposal is that you form an accountable care organization. An accountable care organization, or an ACO, is a group of different healthcare providers who work together to achieve the triple aim. Not only are the healthcare facilities responsible for medical outcomes, but they're also responsible for financial outcomes, with an important emphasis on improving patient care while also decreasing cost. One thing our team would really like to reiterate to you is that this is not going to be an overnight thing. This will be a long-term process, but we want you to start taking these steps sooner rather than later. But why is forming an ACO important for you? An ACO will really help you assess the value of healthcare you're providing the patients in your network. If you see this simple formula, as the quality of care you provide your patients increases, while the costs also decrease, you enhance the value of care you're providing. Another reason this is important is for your goals for the future. One of your goals is to increase enrollment by over 100,000 members in the next 5 years. As an example of this, a rural healthcare system in the Northeast, formed an ACO in 2012. At the time, they only had 9,000 members. They now have over 100,000 enrolled members. So this is just an example how an ACO can help you increase enrollment for the future. Another one of your goals is to become a Medicare Accountable Care Organization. If you establish this Accountable Care Organization earlier and establish that framework with Bluegrass, it'll be easier to work with Medicare in the future. You're probably wondering about the costs, though, associated with our plan. As you can see, the first two parts of our plan really have insignificant costs compared to what they may save you. As an example, the average cost of readmission per patient is around $13,000. Imagine decreasing that by 10%. Now you're probably looking at the startup costs for an ACO thinking, wow, that is outrageous. But wait till you see the potential savings. One thing we really want to highlight in these startup costs, though, is the electronic health record synchronization. We know that all your member organizations have the same electronic health record except for the Winston Transitional Rehab Center. We think it's imperative that all of your member organizations use the same electronic health record to enhance provider communication and integration of care. In Lynette's case, because the Winston Transitional Rehab Center did not have the same electronic health record, she actually had to have a longer stay because of healthcare complications. We want to prevent those errors from happening in the future. Now, let's look at the savings. If we specifically look at the savings associated with an ACO, you might be thinking to yourself, well, I've heard some of the original ACOs had questionable financial outcomes. They did improve clinical outcomes, but the financial data was relatively inconsistent. What you might not know is that established ACOs in Kentucky have actually been very successful, with an estimated savings about 3.45% a year. This was published in an article earlier this year in healthaffairs.org. As you can see, if we apply that 3.45% of savings specifically to Hazard Appalachian Regional Medical Center, that could be over $4 million savings per year. And that's just in one of your member organizations. Now imagine applying that to all the organizations in your network. As far as your relationship with Bluegrass, we proposed a shared savings arrangement. This really goes back to that idea of improving outcomes while also decreasing cost. This will help switch you from that traditional volume-based payment system where you pay per number of services you provide to more value-based payment system. So hopefully you'll improve care for your patients while also thinking about decreasing costs. It's not only a win for your patients with better improved care, but it's also a win for Bluegrass because you're keeping in mind that idea of reducing cost. In conclusion, although Lynette was a stroke survivor, she's left with an impaired quality of life and a pessimistic attitude about the future. Unless her follow-up care significantly improves, she's likely to succumb to more healthcare complications, and she may even have another stroke. Fortunately, though, it gave our team the perfect way to assess the strengths and weaknesses of healthcare in South Tree Health Network. Our plan really looked at finding this new awareness of stroke and stroke risk factors in your network, Perry County, and Kentucky as a whole. We also focused on continuity of care, this idea that follow-up care is extremely important for stroke patients, and they should have appointments set up when they've left the hospital or the rehab center. And not only will the No Stroke Plan improve health for your patients, but hopefully it will also improve their quality of life. We are extremely confident that our No Stroke Plan assesses all aspects of the triple aim. Gillette began by explaining Lynette's story and how much of a problem stroke is for you, but that 80% of stroke cases are actually preventable. Jenny went on to talk about the patient experience. She talked about forming that interprofessional stroke team to enhance provider communication and also hopefully improve patient safety. She also talked about follow-up, that continuity of care, and how important it is for stroke patients. Then, Stephanie talked to you about population health, reaching out to the community to increase awareness about stroke and stroke risk factors. I then talked to you about the affordability of care, forming an ACO as that basic umbrella to hopefully improving clinical outcomes while also keeping in mind decreasing costs. We thank you so much for this opportunity, and we are certain that you should integrate the No Stroke Plan into your network. Thank you.
Thank you.
Thank you.
Question? Thank you. Very nice presentation.
Thank you.
couple of questions. I was interested in the telestroke program and wondering a little bit more detail about that. So if you have their major stroke center, what is it that's going to go on in that program that's going to be helpful to the outlying hospital? In other words, what exactly are the questions, or what does the telestroke program do?
So basically, the telestroke program would give rural hospitals like Hazard Appalachian access to specialists like neurologists or things of that nature that they don't have access to at the rural ones. So for example, after Lynette was given her TPA, she didn't respond to it. And they didn't really know what to do at Hazard Appalachian. They just kind of left her there, and by the morning she was better. With telestroke, they would be able to contact a neurologist or a neurosurgeon and determine what the next best thing to do for Lynette would be.
Yes, so we know that the University of Kentucky already has an affiliation with South Tree Health Network, so we want you to utilize this connection that you already have and not waste it, and use telestroke as a means to improve your patient.
Am I going to have to pay somebody?
So we did incorporate a potential cost, not knowing if you have any of this video conferencing technology already at the hospital, but it's just not being used perhaps. Also knowing that it has to get certified by the Joint Commission, and there's regulations for the quality of the technology. So, you know, we incorporated a cost to, you know, in case you needed to cover for that. But then the Comprehensive Stroke Center, you know, they would have the same video conferencing, and it would be like a two-way.
And then do we pay the neurologist, or how does that work?
They would share the cost of, from my understanding, they share the cost. You wouldn't be, like Hazard Appalachian wouldn't be paying the neurologist at University Hospital.
Kentucky is actually one of the few states that does allow Medicaid billing for telestroke services, so there would be payments for that program.
Oh, thank you.
How about EMS transport in this accountable care organization? You know, Eastern Kentucky is quite mountainous. It's difficult. Access to some of these locations is difficult. How would you envision, I didn't hear any mention about helicopter EMS transport to UK for endovascular intervention if it were needed. And your ideas about a comprehensive stroke center, I think, are excellent, but where would you envision, would that just be at UK, or would that be in this county at one of the regional hospitals as well?
The hope would be to eventually have comprehensive stroke teams at all of our facilities in South Tree Health Network, and having the University of Kentucky system already affiliated with us, we can use them as a basis and a model, sort of because they're already recognized for their stroke treatment. One thing we've discussed using helicopter treatment, but Hazard Appalachian and University of Kentucky is about 2 hours apart, so we understand that is a long drive. But hopefully we get these EMS trained so they understand the severity of what a stroke is and how urgent it is and how they need to operate quickly to get these patients to a hospital fast is something that we really want to target when we talked about giving them that rapid response training. But if a helicopter would be necessary, I think that's something we'd have to consider in the future, because that, it is important. It's the time frame of when these patients get their treatment that's really important.
And also educating the primary care providers, for example, in the community. They did bring Lynette by EMS to the hospital, so that was a good thing. So we would like to continue having EMS.
Right. And educating the community as well as the healthcare providers about the urgency of getting to access to interventional care early. Because I think that your presentation was strong in the community effort, and I think if we can prevent 80% of strokes, that's great. But what can we do to improve that care of the 20% of patients that do have care to decrease their long-term morbidity? And that is get them to a location where they can get TPA or endovascular intervention early. Thank you.
I wanted to know a little bit more about the stroke team. So really just starting at the top with the stroke team leader. Maybe tell me a little bit about the qualifications for that position, how you envision that role functioning, and then with that, just overall the stroke team, how is it activated? How do you envision that team functioning?
So the guideline recommendations say that a stroke leader or the stroke team leader, champion physician, what have you, doesn't necessarily have to be a neurologist or be board certified in neurology. They just have to be willing to learn more about it, and they have to be interested in it, and they have to have a passion for it.
Okay.
So yeah, we would just kind of have to gain an awareness of the healthcare team that's there, and see if anyone would be interested in having that position.
So it would be, I guess we're looking at 3 hospitals, with 1 and 2. So do you envision several stroke teams in each one of those?
Yes.
Okay. I'm just going to jump around a little bit if that's okay.
Yeah.
So ACO, did you, it's kind of a crazy idea, but did you consider possibly having an ACO model? I know this is a rural area, a lot of expense in the ACO. Did you consider maybe a commercial product as well to maybe help drive some additional revenue? So in other words, there's commercial people in the marketplace. We know that. Did you give some thought to that? To an ACO, a commercial version of it?
Would you say with like a private payer?
Yes.
Okay, that's actually our idea, was that you would form this initial ACO with Bluegrass.
Okay.
So you would do it with the private sector payer initially.
Okay.
And then hopefully maybe expand, because we know that actually there's a growing number of ACOs that are contracting, not only with Medicare, but also contracting with private payers. And private payers like that because it already gives them that preferred network.
Yeah.
They don't have to establish that already. We have the network.
Okay.
So that would be our initial goal, and then if everything works out, maybe go through and do the Medicare process at a later time. But the shared savings agreement would be with Bluegrass through the formation of an accountable care organization. Okay.
And then the stroke team, just the costs associated with that? I think I saw $5,000. Was it $5,000? Is that right?
Yeah.
So how did you get to that number?
So it's based on, feel free to say, but it's based on, they actually gave a range in the recommendations and the guidelines for how to form a team, and that's based on not knowing what staff you already have, like if you would have to hire more nurses or physicians or what have you, but you already have your clinical integration network and a large staff as it is. And then also just to consider education, like training and materials that might cost. It could, we're not sure exactly the price, but we just kind of gave a estimated.
Yeah, we already know that there's enough staff in your hospital, and we don't want to be hiring. We don't want you to be hiring any more staff because that would incur more costs. So we want to utilize what we already have and form this stroke team and have these different interprofessional professionals around the hospital work together to improve stroke care at Hazard.
So I got a softball for you. You ready? Okay. So the team that the outreach, I thought was very comprehensive. I really liked that. A lot of thought put into that. What's your confidence level that we could roll that out and be effective with it?
I'm extremely confident that we would be able to roll out that program, especially because we already have a relationship with the University of Kentucky, and they have a lot of health professions there, and then we also have that area health education center. So even though we are dealing with these very rural, hard to access areas, the area health education center, the whole idea of that program is to take these students in health professions and distribute them to the areas where they're really needed. And we could utilize those students very well just by implementing these programs, using the students to administer them, and then using our partnership with Bluegrass to then, they were offering our population analysis services. So by continually monitoring it and utilizing the students, we can definitely roll it out.
And there's also the Kentucky and Southern Indiana Stroke Association that is available for assistance with the hospitals to provide, screenings and to do volunteer things that maybe the hospital can't have, their staff go away from patient care, for example. Then if they needed extra help, they could contact the association.
You have about
5 seconds.
Wow.
Thank you very much.
Thank you.
Thank you.
So into the feedback session. So what was impressive about what you did is several things. One, the whole idea, I don't know if you stole it from somewhere, but the no idea was quite clever and engaging and rememberable. So that would be worth the cost of the consultation just to have that. I really appreciated that you really got into mentioning the risk factors of stroke, so show that you had good understanding of that. Something that was also impressive is you had great slides, but you didn't talk off them. And you used them to substantiate, but the focus was always on you, not on the slides, because the slides you could glance at, get the picture, and then we would come back and focus on you. I like wishbone diagrams. That was a good analysis. I also appreciate the fact that you didn't try to tackle everything. You picked out what you thought was the important elements and went after that. Overall, it was just a good presentation that made a lot of sense. I think from the standpoint of the presentation itself, there's some things that you could do to be just a little bit better than you were. One, remember to breathe. I'm a surgeon. Whenever I operate, you're doing outpatient, you got to breathe. Two, and I always worry about people, what they do with their hands when they talk. Yep. Now, I don't know if you noticed it, but the minute you two ladies opened up your hands, you really opened up yourself to the discussion. And that's something to keep in mind, is to use your hands when you talk. What you do with them when you're standing there is hard. And be sure you pay attention to each other. Maybe look at the person presenting rather than looking into the audience from that standpoint. Appreciate the fact that you didn't do notes. And it's always in 20 minutes. The big deal is to get it all out. It slowed down as you started. Each of you started fast, but then you slowed down and got into it. So y'all did a really good job.
Thank you.
Outstanding presentation. And to reiterate what Dan just said, I like the fact that you initially, when you introduced it, you created, you clearly defined the problem, the increased risk in that portion of the country and so forth. That was well done. I like the fact that at the end you did a very nice summary of this is where we've been and these are what our recommendations are. I think the only thing, and this is a fairly peripheral issue, but I think important in a rural region, is to deal a little bit with the EMS transport and to deal a little bit with this volume actually, would this region of Kentucky have the volume that would really meet the number case criteria to be a Joint Commission certified stroke center? Or if not, a lot of these people in very rural areas are difficult to get access to. It's difficult maybe to get them in within the 3 or 4.5 hour window for TPA, even into a community hospital. And then do you have a good system in place where if they really needed complex endovascular care, could you promptly get them to Lexington? So I think to deal a little bit with the EMS transport issues and how that would be part of the ACO, I think is important. You might be interested to know that along the Ohio River, there's so many helicopter transport programs that those of us that develop standards for and accredit medical transport programs have been worried about the competition between programs to fly. So there's an abundance of rotor transport available in central and particularly northern Kentucky between Cincinnati, Lexington, and Louisville. So thank you. Great job.
Yeah, I would agree. Just overall, the presentation I thought was very well thought out. It's clear to me, very sequential in terms of the way you all set it up. Once you all hit your stride, I thought you did a very nice job. I think breathing is the key. Always not easy to do, but again, once you all got into it, it was very good. It was evident to me that you were confident in what you were talking about. The Q&A I thought was really good. You guys were bouncing off one another, which is what I'm looking for is are you, when you're putting this together and you're working as a team, are you really talking and communicating and sharing ideas? So I thought you did a very nice job with that. I really appreciated the no stroke. I thought that was super creative. Really, really good. I might steal that and take it to my hospital if that's okay. Yeah, okay. Well, I'm in South Carolina, so we got a pretty good distance between us, so I think we're good. But I thought that was really strong. I really love that. The social media piece of it, too, I thought was a very nice touch. The 5,000, I believe you said 5,000 likes. I mean, who would have thunk it in a rural area? That
I like
5,000
was checking every single.
I mean, that's just. But didn't that boggle your mind a little bit that in a rural area like that,
Yeah.
they have 5,000 likes at each hospital? Is that right, or in total?
Almost all of them. Like I checked a ton of different
Yeah.
hospitals.
So I thought that was great that you did that research and were able to connect that, because in my mind that social media is such a that's a great medium obviously to use, and to be able to pull it off in a rural area like that, I think is pretty cool. So well done on that. And staying close to Triple Aim, I thought that was fantastic. You stayed close to that and kept bringing it up, and it was at front and center. And then also Lynette, I appreciate that you kept her at the front of the story as well. So overall, I just thought, again, very well. And I really appreciated, too, the transition of care. I thought that was well defined, and it seemed to me to be doable. So, again, very good. So overall, well done.
Thank you.
Thank you.
When I asked the question of telehealth, I didn't think there was any way you would get the answer that I was thinking of, and you nailed it. And you nailed it.
And one other comment, I particularly liked the detail that you provided about the community educational program. That was outstanding. So thank you very much. Good job.
Thank you.